Greetings. I'm Shannon Decker with the Speedy Foundation, and I am here today to have a quick conversation. We believe that it takes a village to raise a child. And so, what happens when that child is struggling? Who needs to step up to the plate? Who has the power to bring change? We believe that it's going to take the entire village to help. And when we're looking at suicide rates, it's really important to look to data, to look towards healthcare. And so I'm excited to introduce Dr. Anna Radin, the principal investigator for the spring trial with St. Luke's. Anna, welcome.
Thank you, Shannon. It's great to be here.
Thank you. Anna, can you share a little bit about your background and your interest and the work that you've done around suicide prevention?
All right. My name is Anna Radin, and I am an epidemiologist and a research scientist in the Applied Research Division at St. Luke's Health System. I was actually born at St. Luke's in Boise and graduated from Timberline High School, so I have deep roots in this community. But I spent a lot of my early career at CDC in Atlanta and working for State Department before coming back home to raise my family here. So I've been personally affected by suicide because a number of my classmates at Timberline have died by suicide over the years, and because I've had extended family members struggle with suicidal ideation. So this is an issue I care about a lot personally, and my commitment to this work has really deepened significantly when I started to work in suicide prevention research and learned just how much we still do not understand about suicide. And scientifically, suicide prevention remains a really young and underdeveloped field of research compared to other leading causes of death. But the good news is there's more federal funding and more research happening now than ever before focused on suicide prevention. And the science is progressing really rapidly now. So we're very excited to be part of that and to see the field moving forward.
Yeah, that's definitely like the silver lining out of everything that happened with COVID. It feels like
Mhm.
to acknowledge the isolation and loneliness that we feel, and for there to be some funding to support some of this research and prevention is wonderful. So I know that Idaho consistently ranks in the top 10 for states that have the highest suicide rate in the nation. I'm wondering if you could walk us through some of that data and what that means for through your lens.
Absolutely. Give me just one second. I'm going to pull up some slides to share.
Perfect.
Okay, so suicide is a leading cause of death across the US. You can see suicide on this slide in light green is one of the top 5 causes of death for US individuals between the ages of 10 and 45. But when you compare the US numbers to Idaho, this is Idaho specific data now, you can see that suicide is the second leading cause of death for individuals between the ages of 10 and 45. And for people under age 65, it's the 5th leading cause of death in our state overall, which is really significant. This slide shows the age-adjusted suicide death rate in the US in dark blue and in Idaho in green. And the gap in those bars at every single age range, you can see just demonstrates the significant extent to which suicide rates are higher in our state across the lifespan. Um, you can see where Idaho falls compared to other states in the US on the left side of the screen here. That's the suicide crude death rate per 100,000. So there are a cluster of states, mostly in the Intermountain West, with the highest suicide rates. Those are the darkest shaded states. And then on the right side of the screen, I've pulled in some data on the proportion of those deaths that's contributable to different lethal means. So you can see firearm is the highest contributor to suicide deaths in the US at 6.93. Um, a crude death rate of 6.93. In Idaho, our death rate due to firearm suicide is twice that. So really significant difference there. You can see smaller deltas between suicide deaths due to suffocation nationally versus in Idaho, and drug poisoning or overdose in all states in the US versus Idaho. This is the last slide I'll show on lethal means, but this shows for females on the top and males on the bottom, the degree to which firearms versus suicide poisoning or overdose, and suffocation or hanging have contributed to suicide deaths. So you can see the death rate per 100,000. What clearly stands out is this light blue bar, which is firearm deaths in males. And this is Idaho specific data. It does not look like this for every state. So this is when people ask what's different in Idaho, this is one of the things that's different. This is not a political statement. It's just a reality of how people are dying from suicide in Idaho. The picture on the right side of the screen, I took in my pediatrician's office. I was really happy to see some nice gun safety counseling up in that office. And I just think there's more we can do in settings all over our communities to help really reinforce the importance of gun safety, as well as other lethal means control measures to help keep young people and adults who are struggling with suicide risk safe.
So let me hop in there really quick because you're absolutely right. And you had said that you had taken that at your children's pediatrician's office. I love that. I also love when you go into a school and they've got a basket of gun locks sitting there. It's very rare to see, but I've seen it. I've seen it in rural Utah schools. It's a simple intervention. If you are in need of a gun lock, you can request one from our website and we'll send it to you at no cost. We also on mentallycovered.org, you can take counseling to access, counseling on access to lethal means, which is a training to really understand what are all of these very serious, things. How do we have these really important conversations about means of death? It's important in the healthcare system. It's important in the education system. It's important in having play dates and conversations with your neighbors. So thank you for letting me pop in there.
Yes, of course. Thank you. Really important issue. This slide just gives you kind of a picture of what's happening with teens with suicidal ideation and the cascade between ideation to suicide planning to suicide attempts and death by suicide. So these are data from the US in 2020, and overall we had 3 million teens that seriously considered suicide. Among those, 43% or 1.3 million went on to make a suicide plan. 21% of those went on to attempt suicide, and just 0.25% of people who attempted suicide died by suicide. So these numbers should be comforting because I think they really do reinforce the idea that suicide is preventable. And while a lot of people experience suicidal ideation at some point in their lives, there's a lot we can do to help keep our kids and our neighbors and our friends safe. I'm going to keep going. I wanted to just present some data from the 2021 Idaho Youth Risk Behavior Survey. This is the last year that Idaho is participating in this survey, but it has given us historically really wonderful data about what's happening in our youth in terms of mental health. So these data on this slide are specific to Idaho teen girls in 2021. 18% of our students report that they had been forced to have sex, which is a 29% increase over the past 10 years. 55% of our teen girls reported that they felt so persistently sad or hopeless every day for at least 2 weeks that they couldn't do their normal daily activities. That's a 73% increase in sadness and hopelessness in 10 years. And 26% of our Idaho teen girls reported that they had seriously considered suicide within the past 12 months, which is a 53% increase in 10 years. Half of those girls, so 13% of our Idaho teen girls, reported that they had an actual suicide attempt in that same time period. These data show the same suicide numbers, but broken out by sex and by grade. So you can see that suicide risk in girls in 2021 was consistently higher than in boys in terms of suicidal ideation, excuse me. So in 10th grade, that peaks for girls at 30%. For boys, that peaked a little bit later in 12th grade. You can see the differences by sex there. And while females typically have higher rates of suicidal ideation, males tend to have higher rates of suicide deaths. So that's important to keep in mind as well while we're looking at these data. This shows the trend over time in Idaho teens from 2011, when 15.4% reported that they had seriously considered suicide within the past 12 months, to now 2021, a significant increase to 21.3% of our teens. And then this last slide shows the percentage of students who engaged in non-suicidal self-injury. This is an important risk factor for suicide. So this is a really important indicator for us to keep an eye on. You see that sharp increase from 2019 to 2021, which I think is something we'll want to keep an eye on moving forward. So
Thank
that's a
you.
lot to take in. Shannon, I can pause for a minute.
Yeah, I just want to say, thank you for walking us through that. And, as a past educator and as someone who advocates for suicide prevention and mental health, just action, I would say that it's concerning that this is the last year that Idaho is participating in the YRBS survey. I know that states like Colorado are also withdrawing, but they have a much more cumbersome survey. And I have not heard of Idaho replacing this data collection tool with anything else. And so as we start to see our young people really struggling, we're now going to be shutting off the valve of taking in that information and knowing, what the pulse is. And so I just want to stop to share my concern before moving on. So
I appreciate that. And with these data showing us what's going on with our teens, it can be really difficult to kind of process and digest those numbers. But I also think there's some hope here, and we know that there's more that we can do, both on the research side to develop and test new interventions for teens. I think all of us in the community have a role in supporting the scale up of evidence-based interventions. We need to make sure that what we're doing is scientifically proven so that we know that we're using our limited resources in the best way possible. I really advocate for a layered approach to suicide prevention. I like to say that more is more. There's no one solution to keeping everyone safe in the community. So we should be having people engage in evidence-based psychotherapy when they can get in to see a provider. We should also be layering public health approaches on top of that at the community level. We should be doing education. We should be working in schools. We should be screening in healthcare settings. So there's a lot of different kind of layers we can put together. And then lastly, for teens specifically, I think doing more to really meet them where they are at home and at school and not relying always on parents to get them in to see a provider or always on parents to take the first step. What can we do to meet teens where they're already at? So to that end, I want to speak a little bit about some research that we have going on at St. Luke's. In 2019, we received a $3.5 million grant from the Patient-Centered Outcomes Research Institute to do a randomized clinical trial called SPARK, which stands for Suicide Prevention Among Recipients of Care. This is a large study, one of the largest clinical trials in our state, and certainly the largest in suicide prevention ever done. We enrolled 1,520 patients in the study. Half of them were adolescents, aged 12 to 17, and the other half were adults. And I just want to talk a little bit about how this study was designed and what we've seen so far. We're still in the midst of collecting data, so we don't have full results to share, but really the goal of this study was to help us understand what's the best way to provide follow-up care for patients after they leave the health system when they're at home, to help keep them safe in between their appointments. So we studied two different versions of follow-up support. Everyone in the study got a safety plan, and then half of our patients were randomized to receive what we call instrumental support calls. So that's a series of phone calls that are really focused on helping the patient review and revise the safety plan that they developed, making sure that that's working to keep them safe and updating it if they need to. Really doing whatever we can to address any barriers they may be facing to attending their outpatient behavioral health treatment appointments. We know that a lot of really good work gets done in those appointments, but we also know a lot of patients never make it to their behavioral health appointments. So we want to help support treatment engagement and also connect patients with any resources they may need to address risk factors contributing to their suicide risk. So things like transportation or food security or other things that may be stressors in their life that we can help address. That's kind of the goal of the instrumental support call arm. The alternative treatment that we're comparing that to is called Caring Contacts. And Caring Contacts involves sending a series of non-demanding messages of care and support to patients to let them know they're being thought of and somebody cares about how they're doing and is here to listen if they want to talk. So we send these more frequently at the beginning and taper them off towards the end of the 12-month period. Patients can respond if they feel like it, but they don't have to. And when they do respond, a follow-up specialist from our team at the Idaho Crisis and Suicide Hotline texts back and forth with them. So these texts may just look something like, "Hi, Shannon, I hope your week is going well, and I'm here for you if you'd like a listening ear." So really pretty simple, but they've been proven to work really well.
Yeah.
So this is an example on the right of what those messages might look like. And this model is based off of a model that emerged in the 1970s from Dr. Jerome Motto, excuse me, and more recently has been tested using two-way text messages, which is what we're doing in Spark. A study in JAMA Psychiatry in 2019 found that compared to usual care, parents or patients receiving these two-way messages were 44% less likely to have suicidal thoughts and 48% less likely to attempt suicide than if they weren't getting the texts. So
Powerful. It's so powerful.
pretty amazing for something as simple as sending some text
Yeah.
messages.
Yeah.
And I think there is something about the messages coming from someone that is not part of the person's family, is not a friend of the person. There's no reason that they should or feel obligated to care for that person. And so there's something magical in that piece of it,
Yeah.
I think, that really seems to matter. So these are not the results of the study, but these are for the combined data for both treatment conditions for adolescents on the left and adults on the right side of the screen. You can see at baseline, so when people entered the study, about 61% of our adolescents were at moderate or high risk for suicide. 6 months into the study, that had fallen to 29%, and then by 12 months that had fallen to 21%. So some really nice reductions in our adolescents, and the numbers for the adults look very similar. So really, really promising. And we think everyone in both treatment conditions are doing much better. Another way we assess how we're doing is by asking our patients in the study how they're liking the intervention. And so 99% of our participants receiving the phone calls reported that they liked them, found them helpful, and recommend them to a friend. And similarly, 97% of the people getting the text messages. So those are really, really good rates. We're really proud of that and excited that patients are finding them helpful. And then we also have just pages of really positive feedback from our participants in the study about how this has impacted them. So I'll just read a couple of these. One person says, "Thank you for everything. Seriously, you saved my life. You made me laugh when I didn't know what happy was. You talked me through some of the hardest things I've ever experienced, and I can't ever repay you except to say thank you." Someone else says, "I think I talked to you because you don't panic when I'm struggling. I can't be honest anywhere else. Thank you for being that place for me." So just really powerful having a listening ear, and our team at the Crisis and Suicide Hotline that supports this work and does leads these interventions for us is really incredible and really, really good at what they do.
Pretty amazing. Yeah, I just think like reading those, you think about a person who's struggling with thoughts of suicide and how much of a burden they could feel where they don't want to be unloading that to friends and family members. But it's something else to unburden yourself to a stranger, and through technology, you feel less isolated and more connected. So it's powerful to see that data coming in after your long trial.
Yeah. And then as the intervention is getting kind of more attention nationally, so more people are hearing about carrying contacts and wanting to scale it up, we're starting to see different versions emerge. So these are one-way carrying text messages that Seattle Children's is sending out to their patients with suicidal ideation after they leave the emergency department. Patients can opt into this support. Using a one-way model where you text these out, but patients can't respond, is a lot easier to implement because you don't have to staff to be able to respond to crisis texts 24/7 and keep an eye on things. But the efficacy, meaning the effectiveness of this version of the intervention, has not been established. So we don't know if these one-way messages work, if they make things better, if they don't make any difference at all, or if they even potentially make things worse. We hope that's not the case. But we recently received another large grant of $1.5 million from the American Foundation for Suicide Prevention. Very excited about that. so that we can look into that question. And this next study will be called Spring. We're comparing the effectiveness of suicide prevention interventions to guide follow-up care. So the spring trial will have three treatment conditions. We'll have what we call an enhanced usual care condition. So these are patients that are randomized to receive some additional support. We'll be helping do a warm handoff to 988 so they can practice utilizing that resource and feel well prepared to do that if they are in crisis in the future. We will also give them a tailored list of resources and help make sure that they feel like they have what they need to reach out when and if they need support. Then we'll randomize a third of our patients to, on the upper left, one-way carrying contacts like the Seattle Children's model. So we'll send out 25 really nice messages over a 12-month period, but our patients in that arm cannot respond to the text messages. And then we'll have a third treatment condition where we send two-way carrying contacts texts. So 25 messages over 12 months again. And these patients in the two-way arm have the option to respond if they feel like it. They can also reach out between text messages if they need some extra support. And our follow-up team at the hotline will text back and forth with them. So we're really excited that we get to kind of dive in deeper to what we see as the next big question in the space of carrying contacts.
Perfect.
Okay.
Amazing. I just think about this through the lens of education, where we think about interventions through the multi-tiered systems of support framework. And if we've got a young person who's struggling with reading, we can identify what part of reading they're struggling with, and then there's 12 different interventions that we can apply, and we test them out to see which ones they respond to. And the one that works, it clicks, and the problem can be resolved very quickly. If we start to look at suicidality and mental health struggles in the same way, where at the pediatrician's office, at the psychiatrist's office, at the licensed counselor's office, in the classroom, in the faith community, in the youth group, if we all start to understand what are some of these amazing clinical and non-clinical interventions, what really works, that's how we curb our suicide rates. That's how we start to decrease some of that really heavy, hard to understand data. And so I thank you for this work, because I just can't imagine, a world where, we don't have 15 different interventions for somebody who's struggling with their emotions. As in a school setting, it would be incredible if we knew that this one-way carrying contact model worked, and that when someone started struggling at this level, we could apply this, and hopefully that would be the intervention that could turn things around for them. So there's a lot of hope in this.
I agree, Shannon. Thank you for that beautiful summary. And I just think, again, this is never going to be the only part of the answer, but I think definitely part of the solution. And it's just awesome anytime we can add another evidence-based tool to our toolkit that is feasible to deliver at a population level. This is something you can do in rural areas and under-resourced areas. You don't have to have a bunch of clinicians overseeing this for each student, each patient. That's something you could do for a lot of kids, a lot of parents too, and grown-ups as well.
Yeah.
But yeah, it's just got a lot of fun. We're excited about it.
Amazing. Well then, Anna, I've got another question before we part ways. I'm just wondering, from the work that you've done, what action would you recommend that other members of the community take, whether they are in healthcare or education or first responders? What is something that we should be doing to help build upstream suicide prevention supports?
Great question, Shannon. I think one of the most important things we can do related to suicide is destigmatize it enough that we can talk about it. We have to get comfortable talking about it with our kids, with our friends, with our parents, with our neighbors. It needs to be something that you can ask about and feel confident asking about. So I think one of our big lifts is to deliver a level of training that allows our community members and our leaders in schools, meaning teachers and counselors, and our leaders in different areas of the community, just getting people comfortable talking about it, because that goes a really long ways. I think also just being mindful of the scale of the issue in our communities and being advocates for doing more. Because, like you said, Shannon, we need to be able to push for evidence-based support in lots of different settings. And that is going to take a village to get the support we need to do that.
Absolutely. Well, Anna, it's been wonderful talking with you. For those who are tuning in, if you are looking for counseling on access to lethal means training, you can find that at mentallycovered.org. We also have gun locks that you can request, and we'll ship those to you. We do have a training on suicide screening, the Columbia model, which is what is being used in Anna's study. There's all kinds of resources that are available there for intervention, for prevention, as well as for postvention if you've lost someone or following a suicide attempt. I would also contribute that we really need to work on the surveillance. Anna's work is data driven, education is data driven. We need to have a more comprehensive system of surveillance so that when we lose someone in real time, we can identify who's going to be impacted and be able to provide the interventions and supports that are out there. And so, as we are reeling and grieving from many deaths that have taken place locally in the Ada and Elmore County area, we can do a lot of advocacy work, but we need to have the data to know where the intervention needs to take place. And so, that's one additional piece that I would contribute to this conversation. Anything else you'd like to share, Anna?
I think that's great. Thank you for bringing up the surveillance piece. That's something I feel really strongly about as an epidemiologist. And I can't think of another health condition that is deadly and that has a contagion effect where we would not conduct real-time surveillance and make sure that our people that are working full-time in this space have all the information they need about where risk is highest. Because every time there's a death in a community related to suicide, the community's risk rises, and especially the people that are closest to that individual. So we really need to understand that so that we can focus our postvention work right away. So thank you for bringing that up. And thank you so much for convening this really important and really timely conversation.
Absolutely.